Hello everyone, Cole Beeler here. I'm going to be talking about how, when, and why to test for C. diff on admission for patients with diarrhea. So you're admitting a patient with Crohn's disease for worsening diarrhea and abdominal pain. They tell you they've been pooping like crazy at home, but it is obviously hard to quantify this. You suspect this is just a straightforward Crohn's flare and start the patient on steroids. So on the first hospital day, the patient has 3 bowel movements. The second hospital day, they have 5. The third day, you can't even quantify how much stool they're having because it's all liquid. So by the 4th day, you say, maybe there's something else that's going on, and you decide to send a C. diff, and it comes back positive. And it feels like you just ripped the mask off of a Scooby-Doo villain and realized it was old man C. diff the whole time, and you wonder, maybe I should have just checked on admission. And I would totally agree. Now we have to report this case to the CDC like it's something that we gave the patient. But the bigger issue at play is, look at all these apples. By delaying testing, we missed the opportunity to isolate the patient and may have led to cross-transmission during the first few days of the hospitalization. I'm going to talk today about how we should have a lower threshold for C. diff testing on diarrhea that is present on admission, or POA. C. diff that is diagnosed prior to hospital day 4 is not considered to be attributed to infection prevention practices that have failed at the hospital and does not result in hospital penalties from the CDC and the Centers for Medicare and Medicaid Services. I would note that if a patient comes in at 11:59 p.m. on a Monday, that still actually counts as a full hospital day, even though it's only 1 minute for reporting purposes. We still see a lot of stool samples sent on day 4 of admission despite the patient citing diarrhea actually on their admission H&P. This may be due to poor charting, lack of attention drawn to it on daily rounds, or anchoring on an alternative diagnosis. Unfortunately, delayed diagnosis from the community may lead to seeding of the hospital environment and colonization of healthy patients. So you might be saying, I wasn't sure how many bowel movements the patient was having prior to admission, and I didn't want to over-test. And I do appreciate that concern, and you're right. Criteria for C. diff testing in the hospital should be 3 liquid bowel movements in a 24-hour period without alternative cause and with some other sign of colitis like abdominal pain. But this criteria is for hospital-onset diarrhea, not community-onset diarrhea. And I challenge that our threshold for testing on admission should be lower than for diarrhea that develops while the patient is in the hospital because the differential diagnosis is different for these distinct clinical syndromes. The vast majority of hospital-onset diarrhea is not due to infection. Almost any new drug can cause diarrhea. Diarrhea develops in 15 to 40% of patients on tube feeds. Changes in hospital diet and even the stress of the acute illness are very common reasons for patients to develop diarrhea. So instead of checking everyone who has a squirt for diarrhea, our differential diagnosis should instead focus on other causes, and we should only send C. diff if the patient has legitimate diarrhea without obvious causes and some other sort of evidence for colitis. Patients are exposed to many more noxious stimuli to the gut in the hospital than in the community, which decreases the likelihood that C. diff is the cause of their hospital-onset diarrhea. Everyone is afraid of missing C. diff because of the potential for developing toxic megacolon, but these rates may be as low as 0.4 to 3%. I'm not saying that it never happens, but it certainly doesn't happen commonly enough to mean that everyone with diarrhea in the hospital setting needs to be screened for this. The focus should be on testing appropriately, not testing everyone. A higher threshold on the hospital side is based on the fact that C. diff causes a minority of new diarrhea events in the inpatient side and has a predictable syndrome that we can monitor for. In contrast, acute diarrhea that develops outside the hospital usually has an infectious cause, of which C. diff should be considered in the differential diagnosis. In fact, one study of 173 patients with acute onset diarrhea in the community setting identified an infectious pathogen 87% of the time. To me, this says that a patient coming in off the street with a history of diarrhea merits testing for C. diff. In a recent study, these are asymptomatic patients, the authors found that up to 10% of patients were colonized with C. diff on admission, And these patients had a 38% chance risk of progressing to colitis compared to only a 2% risk in non-colonized patients. It's becoming more understood that C. diff is no longer just a hospital onset infection, and patients without healthcare exposure can present with C. diff infection as well. Based on this, I think the data would support asking our patients if they have been having diarrhea on admission and having a low threshold for testing for C. diff with any positive history here. Any diarrhea reported prior to admit should prompt C. diff testing on the next liquid stool. Now, they still need to be having liquid stool, but having a lower threshold here for testing on admission should decrease the amount of hospital onset cases that we actually have. Why should we have a lower threshold for testing on admission? There are actually multiple reasons. First, you don't actually know the volume, frequency, or character of diarrhea prior to the patient coming into the hospital. Patients love talking about their poop, but rarely give reliable descriptions. So testing, even if the history is sketchy, is likely high yield. In the hospital, you can directly observe the imported chocolate to get an objective assessment of whether the patient needs testing. Poop outside the hospital is actually really a black box. Second, as we discussed, you have a higher probability of identifying the infection when testing in patients admitted to from the community setting. And third, testing early means earlier isolation, which means earlier protection of the other patients on the unit. As an aside, we should have a POA assessment of all devices, central lines and Foley catheters especially. If the device isn't needed, remove it. If there are any signs or symptoms of infection, assess the patient and make sure that blood cultures and urine cultures are sent appropriately. There is nothing worse than having to take the blame for someone else's mistake. So be sure to assess your patients for incoming harm. Thanks so much for your time. Remember to test your POA diarrhea for C. diff.